Hey, everybody, this is Jason Wilson with the Curious About Cannabis podcast. Thanks so much for tuning in once again. Today, I'm really stoked to have the guest that I have on today. I have Dr. Janella Chen, someone that we just recently became friends. We have a lot in common, and I'm really excited about our conversation. Thanks so much, Dr. Chen, for being willing to come on the podcast.
Thanks for having me, Jason. I'm looking forward to this.
Yeah, totally. So for those that aren't already familiar with you, do you mind starting us off by just explaining a little bit about your background and how that led into working with cannabis in medicine, and then we'll just kind of spin off from there.
All right. Well, about 1,000 years ago,
right? Yeah.
I feel like it's so long. I was a patient actually before I even became a physician, a medical doctor. I was diagnosed with ankylosing spondylitis when I was a teenager, and it's a big fancy name. It's also called AS for short. And basically what it is an autoimmune disease of the spine. It's an inflammatory disorder. There's no cure. There's really, no treatment that is long term. It's really just maintenance and palliative care. And what ends up happening is your vertebrae, so the bones in your spine, start to fuse together. They literally crazy glue together, and you lose mobility.
Yeah.
So you might see people on the street where they look like they have a big rod in their back, and they're sort of turning, with their whole body. They don't have much range of motion.
Right.
And usually those are patients with AS. And I went through conventional treatment as a teenager and as a kid. I had a lot of pain, but I did, normal prescription medications. I went to physical therapy for many years, did acupuncture, epidurals. I did a lot of injections and trigger point injections, but nothing gave me long-lasting relief. So I wore a back brace while I was in medical school, and this was in San Francisco. I went to school shortly after they legalized cannabis in San Francisco. In California. And I would wear this back brace all the time while I was doing rounds. And one of my attendings pulled me aside and said, what's going on? Why are you wearing this brace? You're having a hard time standing, assisting in the OR, delivering babies. I see that you're sort of standing on the side, trying to sit down, and you're in a lot of pain. I told them I had AS and that I was really disheartened. I was really sad because here I was training to be a doctor. I had at my disposal, hundreds of specialists. I was in this great university, and no one could really offer me any relief. It was sort of the same revolving door. Here's another prescription. Have you tried an epidural? Have you tried steroids? Yes. And there's a lot of meds that I couldn't take. When you're working in the hospital or you're studying, you can't be sedated. You can't be altered in any way. So, surprisingly, he pulled me aside, and this was an HIV and AIDS doctor, and he handed me this bottle, okay? And he said, don't tell anyone I'm giving you this, don't freak out, but this is marijuana. This is marijuana that's in a tincture bottle, and it helps my HIV and AIDS patients with pain. He didn't call it CBD oil or anything fancy like that. He just said, it's marijuana, steeped in alcohol. Take it before you go to bed at night, but it really helps my HIV and AIDS patients. And I completely freaked out. I grew up in the Bronx, and I grew up in a very traditional Chinese household. So there was a stigma surrounding cannabis. I was a pre-med. I had my eye on the prize. I didn't really experiment with cannabis a lot, but I knew, and he said it too. He said, you're going to work 80 to 100 hours a week, and you have a long way to go. And you really are not going to make it, with just this back brace. So I sat with it on my dresser for weeks on end, and I stare at it, and I finally took it. I took it over the weekend when I wasn't on call, and to my surprise, it did make me feel a little funky. It reminded me of when I first had a glass of wine. I got a little flushed, but nothing crazy. But, by the time the weekend was over, by Monday morning, I knew something was working because I was able to stand and do the dishes without the back brace. I was able to do some light household chores without, pain. And I went up to him that next week and I said, what is in this? I said, what is this? And how come more patients don't know about it? And he started explaining, cannabis to me and what it is, what it isn't. He basically took me aside and he says, there's this journal club that meets, there's other MDs. If you want to start learning about this plant, let's, by all means, let's start looking at these different cases. And I made it a point for my career to learn everything I could about this plant medicine, and this was, in the 2000s. So, right. A lot has changed since then. But patients found me. I didn't have to advertise. I integrated into my holistic family practice, and word spread fast because patients could appreciate the fact that they could tell me about cannabis usage, tell me about their other medication usage without feeling like the doctor was going to dismiss them from their practice.
Right. Yeah. Yeah. And that's, one of the huge challenges that it seems like, we face right now with cannabis is getting people to, one, to get the doctors and nurses educated to know how to respond when someone comes to them saying, I want to try cannabis or I am using it, but then also on the patient side to have that sense of safety with the physician to be able to just honestly share what they're experiencing, what they're experimenting with and everything. Because I think, and tell me if you agree, but there's a weird dynamic that's happened in our healthcare system, it seems, primarily based on my own experience, that the patient and the doctor don't always feel like they're on the journey together. And right. So the patient, even though they may have, their primary care physician or their specialist that they see regularly, they don't always feel like, I don't know, they feel very alone in their pursuit of wellness and trying to get better. And so it's almost like this, like the cannabis piece is sort of raising a bigger issue in healthcare broadly that stems from how stressed a lot of doctors are, how limited amount of time they have to spend with patients, all these other pieces as well that I think we need to really seriously look at if we want to improve our healthcare system and have people feel that sense of trust again with their physicians. And I know that I went through a very similar experience. So I have multiple spinal cord injuries. And so I've worn the back braces. I've been on steroids, I've yes. been on all of these things. I totally understand. And one thing that, before you and I had ever talked, I felt this, connection with you because I saw on I think it was a different interview or something, you talking about your personal background. And I was like, oh my gosh, I've been through at least a piece of that. And the same way I discovered cannabis as a patient, before I ever got involved in testing labs and research and all of that sort of stuff. And it was through a very similar sort of thing. I was literally stuck to the couch, couldn't move, had these back spasms and extreme pain. Felt like someone was driving a knife in my spine, just crazy. So I can very much relate to, at least to some extent of what you went through. Because it's traumatic going through that process of how do I find relief with a chronic condition like this, without being just knocked out all the time. It's really hard.
Absolutely. And it takes a huge toll on your nervous system.
Yeah.
You feel like this can't be my legacy. I cannot live like this.
Yeah.
And we're young.
Yeah.
We're young and we're, when you think of someone with chronic pain, you think of grandma,
right, right.
that's in their 80s or 90s, but chronic pain, hits even teenagers I see with overuse injuries through sports, through a lot of genetic disorders as well. So being a chronic pain survivor, I really know what it's like when you tell the doctor, I've tried everything and it doesn't work. Yeah. I mean, you almost don't want to go to the physician because you know the things that they're going to offer you.
Right.
It's either surgery, prescription medications, or PT.
Yeah, exactly. Yep.
Right?
You're like, I've heard the story multiple times. Oh, you want to do another MRI? Okay.
Yeah, exactly. What's going to change? My pain is my pain.
Yeah.
But I mean, really, I think this whole medical cannabis movement is a wake-up call to our healthcare system. Patients are turning away from mainstream medicine. They're heading to forums, to right. listening to podcasts like yours, places like Wendy's Shop, Artemis, CBD Shop, because they're giving them what they need. You as an advocate, they're listening to these podcasts, they're connecting better, and they're looking for a more natural approach to health and healing.
Mm-hmm. Yeah, exactly. And so coming back around, so you're in medical school, you discovered cannabis and were able to start to function better. Where did your path lead after that? Kind of how did the rest of your medical schooling go? And then what did you specialize in?
So I specialized in integrative care.
Mm-hmm.
So what I knew was I understood that, cannabis was part of a holistic movement and that it wasn't going to be the end all be all,
Sure.
even for myself.
Right.
I knew that when I integrated cannabis, then I could get up off the couch.
Right.
Then maybe I could give a breather and take my back brace off for a couple of hours, but I needed to utilize those hours and exercise, do some foam roller exercises, maybe take a trip to the acupuncturist. I'm an osteopathic physician, so I also use my hands to help heal patients. I do manipulation. I work on the fascia and the tendons and the ligaments. So hands-on approach for patients. So cannabis breaks that storm. It sort of parts the clouds a little bit, and then it allows you to do other things. For me, losing weight was a big thing. I had to lose a lot of weight. I gained a lot of weight in medical school. The freshman 15 became the freshman 50.
Right.
Right. Because when you're in pain, you eat for comfort.
Yes, absolutely.
And that ice cream, that hot chocolate just feels so good, right? When you're sitting on the couch. But, an anti-inflammatory diet, I talk to my patients about it. I have a background in nutrition, so that's a really, really big thing. So I incorporate all these different modalities with my patients, and I'm realistic. It might not all happen at once, but maybe it's a start with cannabis medicine and it's a 10-minute walk, getting those lymphatics moving, or maybe it is a massage, something like that. So I try to work around the patients, and that's how we created our integrative health centers in California.
And can you briefly describe to anyone listening that's maybe not familiar with like osteopathic medicine versus allopathic medicine and all these sort of things? Can you describe sort of what that means to be an osteopathic doctor, versus other types of physicians, that sort of thing?
Sure. So there's two types of physicians in the U.S. There's MDs and there's DOs.
Right.
MDs are medical doctors. It stands for medical doctor. DO stands for doctor of osteopathy. Now, we have the exact same licensure. So we work in the same hospitals, the same privileges. I can write all prescriptions, admit you to the hospital, MRIs, insurance companies cover us, et cetera, et cetera. The main difference between doctors of osteopathy is that we take an extra year, sometimes 2 years of anatomy and physiology. So we have a much more deeper understanding of musculoskeletal system. And some of us, very few of us, but some of us go into what's called osteopathic manipulative medicine. And that's what I specialize in. And we use our hands to help heal patients. Now it's becoming much more rare and rare as pharmaceuticals became the mainstream. So most DOs are just like regular physicians and don't do any hands-on medicine. But there's about 3% of DOs, so there's a few of us left that still practice osteopathic medicine.
Yeah.
In its tradition.
Yeah. And what specifically kind of drew you into that route versus the MD route?
My pain.
Yeah.
My pain. So I originally started as a physical therapy major.
Okay.
I knew, I did PT as a teenager, and I thought, okay, well, this is helpful.
Yeah.
Maybe I can become a physical therapist or a chiropractor. I was very interested in anatomy and physiology. So I was a PT at Cornell, actually, and I was going to get my master's in PT after I graduated as an undergrad. And I met a DO actually while I was there, and he adjusted me. He gave me my first adjustment. I was, again, in pain in college already, so I was looking for alternative relief. And I said, what are you doing? You're not a chiropractor. And he said, no, I'm a DO. And I said, what's a DO? And he explained to me about osteopathy, and he says, you're a physician, so you can have all the privileges as a physician, except you learn how to manipulate, and you learn more about anatomy and physiology. So I said, sign me up. I changed my major. I became pre-med, and the rest is history.
Wow, that's really cool.
Mm-hmm.
And how would you describe your experience working with a patient that was trying to work with cannabis for the first time? What was that like?
So for me, it was important having my own experience, because I could relate to patients that were naive.
Right.
I was very, very cannabis naive. I didn't know what to expect. Oh my God, my mother said I would get schizophrenia if I ever tried cannabis, right?
Yeah.
So I came from this really big fear factor. But for me, it was number one was education. What does cannabis mean? Let's break it down to plant medicine, plant sciences. What does it mean to even try alternative medicine? Dr. Andrew Weil is one of my mentors.
Oh, cool.
So I really, looked at that realm as education first. Acupuncture is a really big part of my practice. I was a researcher at Columbia University Women's Health Center, and we research acupuncture and uterine fibroids. So for me, when you think outside the box and you're seeing an MD, the biggest thing is expectations for the patient and education.
Yeah. Yeah. And what were people coming to you to treat? What were some of the common things that you were seeing that people were turning to cannabis for? I imagine pain is one of them.
Pain is one of them, but also I saw a lot of children. Actually, I treated mostly children in California for the first, I would say, 5 to 7 years. Children, and these are patients that have tried everything. Like you and me, they've gone through the whole, 10 different MDs, 10 specialists, and flew all over the country to different, centers, from Maryland to Texas and they've seen all the specialists, and I was their last hope. And they heard that cannabis could work. These were children with epilepsy, children with cancer, mitochondrial disorders, genetic disorders. They came in wheelchairs. They were non-ambulatory, right? They weren't walking. They weren't talking. These were special needs kids. And then it expanded to adults that were in chronic pain, adults with MS, adults living with fibromyalgia, autoimmune diseases, ALS, Parkinson's, where there really is no answer for chronic diseases, no chronic pain diseases.
Yeah. And of some of let's focus on the children for just a second, because I think that's really important to talk about. What were some of the successes and failures that you experienced working with kids in some of these conditions?
The biggest thing with children is, and it was an important part of our practice, is to make sure that there was a team approach, and still is. So I really want to make sure that the child's neurologist, the pediatrician, the psychiatrist is on board when they're working with an integrative physician such as myself. So having that conversation about cannabis, having that conversation with both parents, caregivers, guardians in the room, and the specialists, so that they know that we're all a team here, and we're not, trying to say, get off all your medication. That's not the point when they come see someone like me. It's really an integrative. It's the best of both worlds. So that is the number one thing. And then working closely with parents, because sometimes the spouses are at odds. Mom might say, I'm full on supporting CBD and cannabis, and dad or their partner will say, I'm against it. This is not what I want for my child. Yeah. So again, communication, education, expectations is key.
And when you ran into those sort of conflicts where you might have parents that disagree with one another, or maybe even other physicians involved in the child's care, what were some of the key sort of like pieces of education that would help sort of calm those fears a bit?
For my colleagues, so for other MDs, the biggest thing is sending them, research articles, talking to them about patient cases. And sometimes I'll go and do grand rounds, do a noon conference, a journal club. and talk to colleagues on their level.
Yeah.
What's happening on the receptor level, things like that. And sometimes they go from, sort of folding their arms and their eyebrows are just furrowed and they're really angry to like, they relax their face a little bit and say, okay, this is not voodoo medicine.
Right.
There's actually some science behind it. And also to reassure them that I'm working with the parents. So they're not off getting something off, from who knows where.
Right.
There is some monitoring, there's charting.
Yeah.
So I'm charting everything and documenting everything. The parents that I work with are keeping journals. So we know how it affects IEP, or how it affects, what is the child's teacher saying, or the speech therapist, or OT or PT. So we document everything and we monitor them very closely. There's a lot of follow-ups in the beginning, because I want to make sure that the parents are feeling supported, that they're doing it right, titration of dosing, making sure there's feedback from all the ancillary health practitioners as well.
Yeah. And what were the main modes of administration that most of these kids would use? Were they using like tinctures or raw oil capsules?
In the beginning, it was just tinctures. In the beginning, the parents were, and this is, we're talking more than 10 years ago, they're making their own. They're growing their own, a few plants of their own. So in California, parents were allowed to grow their own cannabis. That was part of the medical cannabis legalization. And they would steep their own, sometimes smoothies. They make teas out of it. Sometimes they would put it in ice cubes, and just put it in their juice, in the kids' juice. So parents got creative, and parents are very resourceful. You're a dad. Yep. I'm a mom. Yep. So we would do anything for our children, and the forums and the support, the community was just astounding. Parents found each other and shared stories and talked about anecdotally what worked and what didn't work. Shared, sort of this like trusted integrative practitioner list, things like that. And we all put our heads together and figured out and tried to learn from each other. Parents, patients teach me just as much as I teach them.
Yeah. And going into what you just said of like trying to discover what works, what doesn't work. And obviously that's a loaded question because it depends on the condition and the person and the dose and all these different things. But what were some of those lessons that you learned working with all these patients about what typically worked better than others? What forms tended to be better than others? That sort of thing.
So for the biggest thing for children, it's getting them to take it, right? The taste, and when I'm treating special needs kids, they're very sensitive to taste. If a lot of these children are on the same diet, because if you veer from texture or taste, they just won't eat it. So that was the biggest tricky thing. That's why moms will make, the ice cubes, or they juiced it, or they steeped it in tea, or they were, really creative and put it in honey or something like that. Ice cream even, whatever they could. So ingestion, just getting them into the child was a big thing. And then also timing. So some children did better taking it before school. Some children did better after school, before therapy even. So we really looked at timing of the medicine. For seizure children, of course, rubbing it sublingually, in their gums was very helpful. Or a lot of the moms made suppositories. And this was, in the very beginning, making suppositories and seeing if it would work. And that was well documented as well. So parents got creative, because when you see your child seizing and this is the only thing that works, and they've tried the conventional anti-epileptic medicines, they tell 10 more families, and then 10 more families come in.
Right. Yeah, and the cannabis that they were using were these THC varieties, CBD varieties, mixture, along the spectrum. What were they working with?
There were mixtures. There were mixtures along the spectrum. The very beginning, we weren't calling it CBD or THC. There's just so many different chemical variants. I helped connect them with different growers, different cultivators, and we knew, this cultivator was able to grow something that didn't make the kid very sleepy, right?
Yeah,
So
yeah.
obviously it was lower in THC, but that's how we documented in the beginning. And as technology changed, as more and more things, information was made widely available. I mean, I use both CBD and THC for children. It really just depends on what the goals are, what the disease, what the symptomatology is, and also working with how functional the child is as well.
Yeah, and you mentioned titration. I think that's something when I was talking with Wendy, that was something we got into because from her experience running a store, she noticed that a lot of people are not exposed to that process of trying to find kind of the minimum effective dose and to know, what you're working with. So can you describe a little bit about, for instance, right now with CBD being so popular, if people are running out trying to, find a product and trying to find a dose, what does that titration look like, and how low do you start, and kind of how much time do you wait to pass before you up the dose, that sort of thing? Just describe a little bit what that process looks like.
So very different between children and adults.
Yeah.
Actually, with the pediatric community, the parents were very familiar with titration.
Yeah.
As you know, even with your baby Tylenol, everything comes in a liquid.
Yep.
And even with anti-seizure medications, things like that, everything comes in a liquid, and they knew how to titrate. They know how to titrate. They know how to, and as a parent, if you look at your child and they have this glaze over their eyes, you already know they're sick, right? That doesn't take much.
Yeah.
Parents are very intuitive. For adults, it's a little bit trickier.
Yeah.
I think we have higher pain tolerance. We sort of kind of just power through things. Or we want instant gratification.
Yeah.
And we want that CBD to work now. Yesterday. How come it's not working?
Right. Yeah. Yeah. No. Exactly.
So it's easier to work with pediatrics, actually.
It's easy for adults too to, like, I don't know, really confound variables and things too when they're sharing what they're doing. And what were the given that children and adults are so different just in like surface area and metabolism and that sort of thing, I know that in the early days you probably didn't have access to really sophisticated dosaging data because there weren't even, I'm trying to think of when testing labs really started to come along. Steep Hill was one of the early ones in California, but that still was not that long ago. But based on your experience now, what are some of those dosage differences between children and adults?
So with children, I'm just thinking of kids that are my autism patients, for example, or kids that have self-injurious behaviors.
Yeah.
That accumulation of cannabinoids can really take a toll on them. So parents might notice that things are working really well for the first 2 to 3 weeks. There's this, what I call the honeymoon stage.
Yeah.
And the child is really, even keeled, grounded, really feels comfortable in their own skin. And then all of a sudden it starts to turn at the 30-day mark, maybe, and they notice that the child is just more hyper. The motor tics sort of amp up, or they just feel like they're a little bit more like hand biting, or the repetitive echolalia, where they're saying things over and over again, that might uptick as well. And I find that to be the case as the cannabinoids build up in their system. So less is more. And I actually find it a little bit harder now than it was when I was practicing in California, because information is so readily available. And there's just, there's 8,000 products available. So parents are trying all these different products, adding this, adding that. How come that didn't work? I read on Facebook that this brand works. So I tried this brand and I added, 0.5 milliliters, another 5 drops, another 10 drops. And so it does get muddy. but really staying the course. And I mean, I sometimes I have to handhold a lot of these parents and just say, no, you want to stay with 0.2 milliliters of this brand for 30 days. Just hang in there. I know you're not getting the results that you're getting, but we're doing it slowly. Then talk about sleep hygiene, talking to the physical therapist or the speech therapist, sort of tweaking things that way. With adults, it's the same thing, being patient, knowing that to decrease inflammation in the body takes time.
Yeah.
And I actually really encourage the adults, let's say we're talking about, chronic pain, for instance, or even insomnia, to add in exercise, meditation, sleep hygiene, getting off the computer and electronics, 2 to 3 hours before bed. So it really takes, I would say, a lot of other approaches,
Right.
not just the cannabis.
Yeah, exactly. And when patients are going through that process and trying to kind of find the, I guess, sort of like the plateau of therapeutic response, how long do you prefer them to wait before, you would make a judgment about what that cannabinoid therapy is actually doing?
A month.
A month, yeah. Mm-hmm.
I know everyone frowns.
I mean, but
they don't want to wait a month.
yeah, I mean, but that's really common with, a lot of other drugs, when you're working with a physician and trying to find, dosaging. A lot of times you might only see a doctor once a month or so, and that's usually, kind of how it goes. So it's not that surprising, but I can understand that that's not necessarily the message a lot of people want to hear. Because they do want to see those results. And, another thing you just touched on is sort of this like biphasic response that cannabinoids have, that at certain dosages, they do one thing, but then as they build or as you increase dose or whatever, you all of a sudden get to this other side of this, curve, this dose response curve, and you may be having less effect or a negative effect.
Yeah.
And I think that's critical. I'm glad you highlighted that, because that's something that I think needs to be talked about more in the context of using cannabis as medicine. And I think that's largely a reflection of sort of this, it's not just the United States, but this kind of mentality that we have of like, more is better. And, if a little bit was helping, then take more and take more. And, we have a sense of tolerance, but that biphasic response is something I think that we don't necessarily have a large appreciation for. And some people, when they might be on that other side of the curve, they might think they've just built tolerance. And so then they add more and more to try to
Yes.
overcome that
Yes.
tolerance.
Exactly.
Yeah.
Exactly.
Yeah.
Exactly. And I mean, and when we look at medicine, we do that at the doctor's office when you're being prescribed blood pressure medication.
Yeah.
Or diabetes medication, you come back and you retest.
Yeah.
Maybe your sugars aren't quite controlled, so we'll adjust it, or your blood pressure, even antidepressants, anti-anxiety medications. Doctors will tell you it takes 6 to 8 weeks to, see if there's going to be a therapeutic response. And if it doesn't work, they're going to have to switch to another medication. So same thing with pharmaceutical medications. And I know you have Kevin Spellman on before, and I adore him. But we're looking at this plant that's affecting so many receptors that that's why everyone is so different.
Yep.
Right?
Exactly. Yeah. And as much as we understand now, it's still only, this fraction of a piece of a puzzle that we're trying to piece together. One thing I really enjoy talking to Kevin about in that interview is, about the endocannabinoid system and just how complicated it is, and that, we kind of have maybe some general understanding of some of the things it's doing and the other receptor systems it's connected to and all this sort of thing, but we're still a long way. And this came out in my interview with Ethan Rousseau as well, that we don't have good ways of measuring this system. The definition of the system is like rapidly expanding as we learn more. And so it's really tricky. And sometimes I think there's a perception, especially within the cannabis industry in general, that, we know so much. And so we should be able to use that information to really target treatments and, make super informed decisions. And we can definitely make better informed decisions than we ever could. But it's just not quite there yet. So a lot of it is still trial and error, moving slowly, trying to control as many variables as you can, and proceed with caution. And
Yeah, absolutely. And I see a lot of women in my practice now, and we have to realize, and this doesn't get discussed as often as I would like, is that estrogen makes women a lot
yes,
more sensitive to cannabis,
yes,
and mostly THC. So our hormones interact with THC quite a bit, and our cycle can
mm-hmm.
influence how we feel. And this was documented through researchers at Washington State University. They found that women experience most effects of THC when their estrogen is peaked,
Yes,
right?
yeah,
Right when it's peaked and beginning to fall. So this happens at like about the day or two before you ovulate, so day
mm-hmm.
12 to day 14 or so. And this interaction makes us more sensitive to the compound in general, but it also actually gives us more pain relieving effects
Right.
compared to males. But also, we actually can develop more tolerance to the THC compared to men. So for women, I actually, when they come into my office, I will look at their cycle or non-cycle, so I'll look at
Sure.
their estrogen, progesterone levels, LSH levels, FSH levels, and I will actually create a game plan, and I will dose them based on their cycle. So they take a little bit more or a little less depending on where they're at. And it's important. I mean, we're not represented in studies,
Yep.
as as an ethnicity, different minorities, or even as a female, which is unfortunate. But I do take that into account when I see female patients.
That's really great to hear. That was exactly where I was going to go next. Is there's this like very little discussed issue in biomedical research in general, that a
Mm-hmm.
lot of the way that we've come to think about pharmacology and physiology is based on research in men, and it doesn't translate. I mean, some does, but obviously there are big differences, and these hormonal differences drive all sorts of nuanced differences in pharmacokinetics and things that really needs to be talked about more. I mean, there's so many issues with biomedical research right now. So this is one. So the underrepresentation between ethnic groups and sexes and that sort of thing. But then also we have a reproducibility problem too. So there's a lot of biomedical research that's been done that we're having trouble reproducing, and it's a great time to have a lot of humility. I think when it comes to medicine.
Absolutely right.
Yeah.
100%. I'm so glad you said that. I mean, when we get sick, you're going to take the same Z pack as I am,
Right. Yep.
right?
Yep. Yep.
So why aren't we dosed differently based on our weight, our ethnicity, based on our metabolism?
Right. Yeah, exactly. And are there I mean, you just hit several of the big ways that cannabis can affect women differently than men, or really just depending on a person's hormonal levels, regardless of how they identify. Are there any other big differences that you've noticed in how people react to cannabis differently that you think people should be aware about?
Actually, ethnicity is a big thing.
Mm-hmm.
I've noticed in my clinical data that different ethnic groups, depending on genetic makeup and where their ancestors are from, will react differently to cannabinoid medicine. So the Hispanic population, Asian population seem much more sensitive to cannabinoids. And so I mean, it's interesting because I'm looking at the data that I have,
Mm-hmm.
and I would definitely want to utilize this data and figure out, where, or maybe we can brainstorm offline,
Yeah.
but really think about how this plant is working from a demographic point of view.
Yeah, that's something that I don't know if I've heard anyone really bring much attention to that at all. So that's super, super fascinating, and something that, yeah, we really need to look at. And once again, this is one of those things where cannabis sort of leads into these discussions about medicine broadly, but this is research that needs to happen across the board, analyses of large data sets that clinicians have, and try to understand how different people are reacting to things differently, and how we can drive medicine towards a much more individualized, targeted approach, rather than how we've been operating since, I don't know, the 50s, where we basically take averages of medical research and we apply therapies according to sort of an average sample population that doesn't even exist in the world. You're always dealing with people that are bringing unique things to the table. So that's excellent to hear. When someone comes to you and they want to engage cannabis, what are some of the things that you screen for that could be problematic, like certain medical conditions they may have that wouldn't react favorably to cannabis, or other medications, contraindications you're worried about, that sort of thing?
Yeah, so medications is a big thing because most of the patients that come to me are on a lot of meds, right?
Yeah.
Because you've already tried all these different things, and all your specialists have tried to throw the kitchen sink at you, so they might be on antidepressants for chronic pain, such as Cymbalta, for example, is something I see a lot. And, patients are trying to get off of a lot of these medications. So I don't recommend just going cold turkey and getting off of these medications because your body's biochemistry has changed. Your brain biochemistry has changed. So if you've been on benzos, antidepressants, if you've been on these pain medications, for your condition for a very long time, just haphazardly adding cannabinoid medicine or even other nutraceuticals, right? Other supplements can be a really dangerous thing. So I make sure that I look at the medication list, cross-reference it, and sometimes patients have to really wait, and I start to wean patients off with their specialist. So I don't take patients off medication on my own.
Sure,
I make sure to work with their MD as well, and help them wean off the medication, and then we fold in the cannabis medicine or some of the other integrative therapies very, very carefully, taking into account the withdrawals, both physical and emotional withdrawal. And sometimes we have to compound the medications. So for instance, I'm trying to think of one that's actually really, Ambien is one. Let's see, we have to sometimes compound the medication so they're taking it. I mean, you can only break the tablet so much.
Right. Yeah, before it just goes to powder. Yeah.
Exactly. So sometimes we'll compound into a liquid form and help them wean off, like Klonopin. That's what I'm just thinking of. Klonopin can take patients 1 to 2 years to get off of.
Wow.
So we'll create it into a liquid formula with a compounding pharmacy, and just drip by drip, and getting them off little by little as we fold in the cannabis medicine.
Yeah. And have you encountered any examples of adverse reactions between cannabis and someone's pharmaceuticals, maybe even before they came to see you, because they maybe didn't have that advice at the time when they started trying it?
Yeah. So cannabinoids can work on your serotonin levels, and if they're on other medications that also affect that, patients will feel much more anxious. Patients might have increased panic attacks. They might feel more restless and just feel uneasy. They always say, I feel like I'm crawling out of my skin. I did something wrong. I took too much, or they're not spacing it apart with their other medications or supplements. Sometimes patients are on 4 or 5 different supplements as well that they think, oh, it's natural, so I'll just take everything at once. And that's not a good idea either. So we really try and break it down for patients so it's much more manageable and cost effective, because that's a big thing as well. As you know, the CBD and cannabis is very expensive. Nutraceuticals are expensive. Then they have their prescription medications on top of that. And then they want to do all these other therapies as well. So we look at everything from a practical perspective.
Yeah, absolutely. And what was in changing gears a little bit here, but what was your experience like going from California's medical cannabis system to New York's medical cannabis system when you moved? What were the difference, and what was that transition like?
Well, there's definitely pros and cons. In California, it was a free-for-all. There was a dispensary on every corner, more dispensaries than Starbucks. You can imagine. So it was very difficult. I had a few of my favorite dispensaries, my preferred dispensaries, where the staff was, wonderful, and they supported my patients throughout the process. But in the beginning, I would actually talk to these dispensaries and say, okay, my patient's going to come in, give you a heads up, without disclosing. I mean, I kept full, HIPAA rules, but giving them a heads up that my patient's coming and this is what we would like to try or not try. And some of the really good dispensaries were very respectful of that and worked as a team. Some of them weren't and was just trying to push product and just move things off the shelf. In New York, it's very different. In New York, every dispensary has a pharmacist.
Oh, interesting.
Every dispensary has a pharmacist, and everything you pick up is logged into the prescription monitoring program. And this is the same prescription monitoring program as if you saw your family practitioner and they prescribed medication for you, like Ambien or some pain meds. They would log it in, so when you go to CVS or Walgreens to pick it up, CVS and Walgreens log in and sees that you have cannabis as well, that you picked it up from the dispensary. So we're all looking at the same database. So that they know that you didn't pick up too much. And the pharmacists at the dispensaries here in New York will say, hey, wait a minute, you're on blood thinners, you're on, Oxycontin, and then you just picked up cannabis.
Right.
There's some polypharmacy going on here. There might be some issues, and they'll pick up the phone and they'll call me. So there is some accountability and cross-reference. So it is a very robust medical system in that sense, but it's very cost prohibitive here in New York. It's about, I would say, 2 to 3 times the price as California, easily.
Yeah, and that's such a shame when you have, some of these patients being children that are already on, sometimes really expensive medications, or like the elderly and the poor, that are already struggling to pay for healthcare, and then to have something like this that theoretically could be really cheap, but making that less accessible, that's disappointing. But it is exciting to hear about a medical system where they're treating cannabis just like any other medicine or drug, and that there's that shared information, and that you can catch things like that there's it's a more precautionary approach, I guess. And that's exciting to see. I'm not familiar with New York's cannabis laws in general. So what are the conditions that New York will approve somebody for medical cannabis?
Right. So there's epilepsy, there's PTSD, chronic pain, which is a big umbrella term, and that chronic pain could incorporate many different disease states: ALS, Parkinson's, irritable bowel disease, which is Crohn's, colitis, etc. Also substance abuse. Actually, they added substance abuse. So patients that are trying to wean off opiates are qualified as well. There's a good amount. Autism is not on there.
Really?
No. But patients with chronic pain, that could be migraine, that could be pelvic pain, that could be arthritis. And like, for example, the cost, going back to cost, I have a patient who is 7 and he has seizures. He had about 100 seizures easily a day. And he is controlled now with cannabis, the seizures. Maybe he has a handful a month now, but they spend about $3,000 a month. Yeah, they spend about $3,000 a month on the cannabis.
Wow, gee whiz.
Yep.
And what's your experience been regarding in getting more into like the more modern work that you're doing, where you've actually got this data? But so there's this debate around isolated cannabinoids versus quote unquote broad spectrum versus full spectrum, which these terms aren't even really defined. So depending on who you talk to, they mean different things. But have you had any? Have you noticed any trends between different types of cannabis products and their efficacy and sort of the dosaging and stuff? And the reason I ask is because I've had some other clinicians tell me that from their experience, they feel that they're able to use lower dosages and get fewer negative side effects with cannabis products that have a broader phytochemical diversity in them versus those that are very, either isolated or like you have, distillates and stuff that have, a very narrow range of chemistry in them. Do you have any thoughts on that?
Yeah. So for me, of course, full spectrum seems to get a little more mileage I find that the efficacy of full spectrum is goes a longer way for patients, and they spend actually less money because they need less over time. I think with isolates, patients tend to need a little bit more. And that's going back to that single molecule, right? So you're pulling this out of the plant, the full plant, and taking it out of context.
Right.
So you may not get all the benefits, but I can see why isolates are used in food and beverage, things like that for taste, or if it's harder to standardize a full spectrum plant, right? So the same chemovar in Florida will look different than that seed in New York or California, right? You're just not going to get the same thing. So I can see why certain industry professionals are more comfortable with isolates, but I think full spectrum is better.
Yeah. Yeah. Well, you're another one to the list. Pretty much every clinician I've talked to has shared the same thing. I'm yet to find anybody that has had a more positive experience with isolated cannabinoids than full spectrum.
Well, I think we can all agree that we just need more research, right?
Exactly.
And this research really needs to focus on the fundamental understanding of what's going on with the whole plant.
Yeah, right.
And not just selecting out these individual molecules like CBG, CBN,
right.
like we know what we're doing, because really we don't.
Right.
So, and the thing is, we're still looking at this field from a disease target kill model.
Exactly.
That's the thing. Allopathic. Yeah. We're still looking at this from this allopathic reductive approach, which is separating disease into parts.
Yes.
Right. We're still separating it. We feel good about separating things by element and component. When we see the doctor, you're going to your endocrinologist and then your nephrologist and your neurologist, and all these doctors are not talking to each other because they're operating in separate silos. So it's the same thing with cannabinoid medicine, and it's a disservice. Really, there's this whole universe of regenerative medicine, nutritional medicine, preventative, integrative medicine, and we're not talking about that.
Yeah, no, absolutely. And this sort of segues into a really broad topic that I kind of wanted to talk to you about. Is just like these plant-based or even fungal-based medicines in general. In your mind, sort of stepping back and looking at healthcare as a whole, how do you conceptualize medicinal plants and those sort of things, and maybe even to an extent too certain like dietary supplements and stuff that are basically medicinal, some of them medicinal plants that are just kind of ground up and capsulized, but how does that fit in your mind of the whole picture of healthcare broadly?
Well, it goes back to what Kevin Spellman talked about in systems biology approach. Right? This is really, again, a wake-up care to our health system. When we look at evidence-based medicine, it really overemphasizes randomized, double-blind clinical control trials. It's looked as it's like the final arbiter of clinical decision-making. Right. But when you look at Americans, more than 40% of us belong to, again, a racial or ethnic minority. So what are these differences in genomes? Yeah. How do we take a closer look at these patients, and how are they participating in these clinical trials? There's actually something that's really interesting I want to bring up. The NIH actually has something, I'll send you the link. It's called All of Us Research Program. Okay. And it talks about precision medicine. And I think this is the future of medicine. It's looking at all of us to participate into this database, if you will. And it's basically contributing your blood tests, your urine, saliva tests, DNA tests. And they're looking at this database to start looking at how do we get more precise medicine. Going back to that Z-Pack analogy, why when you get bronchitis or you get a cold, a flu, why are you going to take the same Z-Pack as I'm going to take? It might not work well. And I think this is where plant medicine can really take hold as well, because precision medicine can take into account plant-based medicine and holistic healing.
Yeah, absolutely. And something I'd like to see from, sort of maybe that it would come from the FDA, but some sort of better way of studying in a sophisticated clinical way how medicinal plants can be utilized in, any particular sort of like treatment modality. And, in other countries, in some countries, they have, a specific sort of pathway that you could
Mm-hmm.
get natural products approved as medicines. And it's a lot harder in the United States. I don't know that I would say it's impossible, but it is very difficult, and it costs a lot of money and a lot of time. And because of that, it's not worth it for a lot of companies to try to, create some basic standardized botanical extract and try to get that approved as a medicine when they could go further and get some isolated compounds, create a very unique formulation that has a much stronger patent on it, that then they can kind of run with for 10 years or whatever once they get done.
Exactly. Exactly. There's not enough studies on plant pharmacogenetics.
Yeah.
We need to look at really genomics more too. I mean, for one big thing that I see in my clinic is that African Americans and Puerto Ricans, for example, they don't respond well to common asthma controller medications as well as other ethnic groups. So this is something we might think about when we talk about plant pharmacogenetics. Maybe there's something in the genome that we need to take into account so we don't overprescribe.
Exactly. Yeah.
So that's the future of medicine.
Yeah.
It's looking at these different. I mean, we don't know anything,
Right.
and we're acting like we know.
Yeah. Yep. Yep. Well, there's that, that classic idea that I try to bring up time and time again. But, the more you learn and the more you study, ideally, what happens is you start to learn how much you don't know, and, and it, and that's, to me, that's what wisdom is like recognizing, your own sort of boundaries, and recognizing that there is, Kevin put it well, this dark information, dark data, dark
Oh
pharmacology
yes. Oh
that we
yes.
just don't understand. And looking at studies, in vitro or even, rodent in vivo models, they don't give us the full picture. And an interview I released recently with Jason Miller, who's a traditional Chinese medicine practitioner. He was talking about the difference between efficacy and effectiveness research. And,
Mm.
that going to something you said just a little bit ago, that most research is targeted on disease, what drug is going to influence a disease in a particular way, not what treatment modalities as a whole might lead to a better outcome for a person. Because, yeah, you might knock out that disease, but what's going to be the consequence for that person's well being, then and, long into the future and everything. And that was something I really resonated with when he said that, is absolutely like our focus has been, we've had such an extreme tunnel vision on disease and not overall patient care and wellness in its totality.
Exactly. There's no talk about prevention. What about the terrain that's breeding the disease? Why is it that there's certain people that will be more prone to cancer than
Right,
others?
right.
So we need to look at medicine from this preventative perspective,
Yeah,
and we don't talk about that in healthcare because there's no time.
exactly. Yeah,
My colleagues are seeing 30 patients a day. It's a
yeah, it
factory.
is. Yeah.
Maybe you have 5 minutes with your doctor and you can't get all your questions in, and you're going to have to wait until the next visit, which is going to be 2 months
Hmm.
from now.
Well, yeah, and I know just from my own experience that I'll have questions thought of that I want to ask my doctor when I go in, and then in the moment when they say, "So, do you have any other questions?" I'm like, I guess not. I don't remember, and then you get home and you're like, dang, I wish I would have asked this and that. And, that's such a common experience, I think, for so many people. And, when you're in the room and, maybe the physician's sharing some new information with you. And so you're processing that and trying to remember, it's hard when you've only, got like 10 minutes, maybe a FaceTime, and then,
Yeah.
that's it. It's really, really hard. Um, Going back to thinking about your interactions with patients when they're coming in and kind of getting on their perspective, what are some of the most common questions that you receive from patients about cannabis, and this leads into another question I have about sort of common misconceptions. Well, we'll start just with sort of the common questions you receive about cannabis.
The biggest thing is most patients wanting to come in is wanting to use them, throughout the day and at night as well. They want to be able to use something without being impaired.
Right.
I think that's the biggest thing. Everyone is working. Everyone's, they might not have a 9 to 5, but they're doing stuff at home. They're taking care of their own parents or their children or friends. So it's impairment. That's the thing. They come in, they say, okay, I need something for X, Y, and Z, but I don't want to be impaired.
Yeah. And have you identified sort of some ideal CBD THC ratios that help people avoid feeling impaired?
Most of patients that take CBD or a CBD dominant formula are not impaired. But there are patients that do take CBD that feel impaired. And that's usually the same patients that are sensitive to, Advil, for example.
Interesting.
And so I'll, just have them switch and have them take it, during the evening. But microdosing is the biggest thing. If you are taking cannabinoid medicine, maybe the first couple of weeks you feel different. You might feel a little bit groggier, but over time your body gets used to it. And you feel less of those side effects.
Yeah, no, exactly. And so leading into the next question, what are some of the most common misconceptions that sometimes you have to confront when either from patients that come in and sort of have a rough understanding and maybe it's not quite aligned with reality, or from your colleagues potentially that have misconceptions about cannabis and its role in cannabis? What are some of those that you run into?
A lot of, I think, with all the hype and, this is really unprecedented. There's nothing in the world that's taken, both recreationally and medicinally.
Yeah.
So I think a lot of patients come in thinking this is going to be it. This is going to be the end all be all. And they have really high expectations of it working because of everything they've read online. And, my neighbor took it and she's free of cancer now. Or it stops the Parkinson tremors, so it must be able to stop my fibromyalgia pain too. So it doesn't work for everything and everyone. It's not that silver bullet. You really have to do other things in combination with the cannabinoid medicine.
Yeah, absolutely. And would you say that's maybe kind of one of the big things that you wish everyone knew about cannabis before engaging it, is that it's not a silver bullet?
Absolutely. And you might not find one product will work, forever. So I usually have patients pick, 2 to 3 different favorite cannabis products that work or close to working, and they switch off, every quarter, because our body gets sensitized to it. And I always compare this to allergy medication. You might find that Zyrtec works for one season and then you got to switch over to Claritin.
Right.
And same thing with your, echinacea or vitamin C or your magnesium. You need to take a break and switch off. The good thing about, our endocannabinoid system is that we can exercise and increase our anandamide levels. We can get acupuncture, massage, and our anandamide levels will increase. So there are different things that we can do with cannabinoid medicine.
Yeah.
Safely.
Yeah, absolutely. And what is something throughout your experience with patients that has surprised you, either an outcome, or however you want to think about that question? But, you've been doing this a while now. Do you have any examples of some things that went differently than you expected, or that an outcome came about that, you really learned a lot from, that kind of surprised you?
What's really surprising and really refreshing is that patients that might not have been into holistic or integrative medicine, when they try cannabis and it works, it's really empowering for them. For the first time, they feel like I can take control of my health. Like I can have this conversation where it does a little bit and then I can do other things. and it really opens their mind,
Yeah.
I think, for integrative medicine and plant medicine. And these are, patients that have been on, maybe 10 medications their whole life, and keep going back to the doctor and says, okay, yes, I will take this new med. Oh, you want another medication? Yes. And they're very compliant and obedient. But when they've had enough and they've tried cannabis and it works, and they start to get off the other medications, they find that very empowering. They find that, like, oh my God, like I don't have to rely on pharmaceuticals. Having that conversation about nutrition and exercise is very empowering, because they don't have to rely on going to the MD and writing that next script.
Yeah, and that's something that has been really exciting for me too, on the sort of the educator side, is seeing, when I teach somebody about the cannabis plant and the chemistry, how it affects the body, all these sort of things, and then I can use that as a stepping stone to say, oh, and then there's these other plants that have these similar compounds and act similarly, and then it's like, whoa, I didn't realize, that echinacea has these alkylamides that interact with the endocannabinoid system, and turkey tail mushrooms, the polysaccharopeptide is interacting with, and flavonoids in general, a lot of them are tugging on that ECS, and that beta caryophyllene, which is in so many plant oils. Black pepper is the most common one that gets talked about, but like, oh, that's now sort of being thought of as a cannabinoid. It just opens this doorway into appreciating food and medicinal plants in a totally different way, that for whatever reason they just weren't able to, there was sort of this invisible wall that they couldn't get past, to kind of see how very real all of those dynamics are. And that's something that gives me a lot of fulfillment as an educator, is like, yes, like you're going beyond cannabis now. And that's, I've mentioned before that this podcast and the work that I do, it's really a Trojan horse to talk about these other areas of health and wellness. And I also follow that up by saying, I'm not the best example of someone taking care of their health. I do what I can, but there's plenty I'm deficient on. So I have the educator syndrome of like, do as I say, not as I do, please. But
It's like the cardiologist smoking cigarette, right?
right. Yeah, it is. Yeah, I'll teach someone about medicinal plants, and it's like, all right, I'm running low on time, got to go grab some fast food.
Believe me, I was at Shake Shack with my kids the other day, and I saw a patient. I was like, oh my God, I gotta hide.
Exactly.
I'm guilty.
I know, right? We're all human. There's only so much we can do. But
exactly. And you're right.
And it's exciting. It's exciting to see when people can connect those dots and start to see, coming all the way back around to like this integrative medicine approach, to see their movement and their diet and supplements, the tea they drink, all of these things as being part of healthcare. And is something I've mentioned before in another interview, but we, at least it seems like it's changing now, and we talked about this earlier, that a lot of times we grow up thinking that you eat food to stay alive, you take supplements if you have a nutritional deficiency of some sort, and you take drugs to get better from illness. And that's such a weird, broken model. It's going to take time culturally for us to kind of get past that. But I know as a kid, that's what I sort of absorbed, from what I was taught and exposed to. And then I got older and was like, dang, okay, well, this is all totally wrong.
Right. Well, what the great thing is that you have platforms like this to educate and to reach so many people. And there's wonderful practitioners, ancillary practitioners. I mean, you have Jana Champagne, epigenetics, nurse practitioners, nurses, health coaches, chiropractors, naturopaths, Ayurvedic medicine, plant specialist. Look at Kelvin. Oh my gosh, he knows a lot more than your normal MD.
Yeah.
So you don't always have to go to your MD all the time. I mean, there's all these great resources that are at your fingertips.
Right. Yeah, exactly. And I guess, so to get into another question I wanted to ask you is on those that topic of resources, what are some of your preferred learning resources regarding cannabis?
Oh my goodness. Well, I have I have this
Oh my
resource.
gosh, you make me blush.
There's some really great resources out there. It's the also the thing is there's also misinformation, right?
Yeah,
So
yeah,
a lot of cut and paste.
yes,
We're
yeah.
sort of echoing the same thing, but there's some really great resources. I'll send you a link and maybe you can put it in your show
Yes,
notes.
absolutely. Yeah, that'd be great. That's something I always try to tease out of my guests to try to understand what you found most
Hmm.
valuable and try to connect people to that. That'd be great. Um, and now taking a step back and looking at sort of cannabis science and cannabis research as a whole, um, what sort of interests you the most, and what do you hope to see from the future of cannabis research?
Oh my goodness,
Big
a
question.
lot.
Yeah.
That is a huge question. The thing about research, especially for plant medicine, is that not everything is going to fit into a
Yep.
box. And I just had this conversation with Kevin a couple of weeks ago, and we're trying. The thing about that's the thing about research is that research has to be double blind, right?
Yeah.
Research has to be random controlled, and then what are you going to make of a plant that has different compounds
Hmm.
that you can't standardize? So it's almost like Mother Nature's laughing at us,
Right. Yeah. Yeah.
right? And then you look at the different receptors. There's a really great receptor map that I use in my presentations of the ECS and how different phytocannabinoids
Hmm.
affect. And it's just scattered everywhere. You can't even. It's like we're a blip.
Hmm. Yes.
There's no way to wrap your head around it, and that goes back to dark pharmacology.
Hmm.
Think about plant medicine. There's no way to wrap your head around this research, and that's why I talked about that NIH platform,
Hmm.
because if we can contribute the different information, the genomics,
Hmm.
our blood, our urine, our DNA, we can really look at precision medicine, individualized medicine. And that's not what we have right now.
Yeah. Yeah. And it makes me wonder, if we're in this situation where we're sort of like a bacteria trying to understand a human, like there's this um, barrier to understanding that you can just like really never get across. And it makes me wonder if, and I mean, I know to an extent this is true that, the role of AI and machine learning is going to become really invaluable to help us try to extend that sort of boundary that we have to work with. Because you're right, like there's so much data, so much information. There's no one human brain that's going to be able to synthesize all of that and digest it and then work with it. I think it's going to take some help from something beyond what we're capable of, and maybe that's a good role for AI in healthcare is like this NIH data gathering initiative to get all this data together in one place where it can be manipulated and analyzed and everything, and then maybe we sick the AI bots on it and then try to figure out what wisdom they can pull out of it and teach us, because otherwise, I mean, can you imagine how much time just time alone, not much, I don't know if you're like me, like any study I read, you've got to read it multiple times to try to like understand the pieces you missed and how things fit together, and so just the time alone is an impossible feat for anyone to overcome.
Exactly. And the important thing also to know as we scale up AI is that, we can't simply base it on data either,
Yeah, yeah.
right? So
Hmm.
there's a sweet spot.
Yes.
And how do we use AI successfully? Right? So we're not, so that we're not looking at false correlations, but
Yes.
we're really trying to understand what's happening behind it. So I think that's the future.
Yeah, yeah. No, that's such a good point to bring up. There are things to our human experience that we're not going to be able to quantify, that an AI is going to be able to pick from. So finding that blend, and maybe that's when we just upload our consciousnesses into robots,
Oh,
and
yeah.
so we can make the ultimate doctors.
Yeah.
But yeah, absolutely. There's a balance there for sure, and there are things to our experience and wisdom and things that AI is not going to be able to overcome. So yeah, absolutely.
Mm-hmm.
Well, I don't want to keep you too much longer. You've already been very gracious with your time. We've been going for almost an hour and 15 minutes now. But I wanted to ask you if there's, in the last several minutes that we have here, is there anything that we haven't talked about that you'd like to get into? And if so, let's do it. And if not, then I'll just kind of hand the platform over to you to talk about anything regarding how people can learn more about your work and contact you, or anything else you want to share. It's
Well,
in your
thank you so
ballpark now.
much.
Yeah.
Thank you. This has been so much
Yeah,
fun.
I've enjoyed it. The
I
time's
feel like
flown
we
by.
can we can talk. I know. I feel like we can talk for
I
hours.
know.
But we covered a lot of really great, pertinent information. I definitely would love to get back on maybe in a few months and see if things have changed and we
Yeah, that'd
can
be
chat
great.
again. But patients can find me at drjunechin.com, drjunechin.com.
Perfect. Awesome. Well, once again, thank you so much. And yeah, I definitely would love to reconnect with you. And at some point, I'm going to make my way out to New York, and then we'll have to get together in
Yay!
person and do something. That'd
Great.
be
Get your
great.
family over
Yeah,
here.
yeah, we're determined. It's just a matter of time. So, um,
Sounds good.
awesome. Well, thanks so much. And for those of you listening or watching, if you want to learn more about Curious About Cannabis, you can go to cacpodcast.com and you'll find all the episodes as well as links to like our YouTube and all of our social media platforms. We're on Facebook, Instagram, and Twitter. And thanks so much for listening and tuning in. And I'll talk to you soon. Thanks. Bye bye.